All right, it's with great pleasure that once again we bring another speaker to you. Alan Morgan is the Executive Director of the National Rural Health Association. We're running a little bit behind on time, so Alan, I don't want to eat up your time, so if you'll go ahead and the floor is yours.
Thanks, Mike. I really appreciate it. And so good to see you again, Mike, and appreciate the opportunity to be here today. This is obviously not the format that we all were hopeful for, and this is most certainly not the presentation that we were hopeful for. Let me see if I can possibly share my screen here with everyone. There we go. I think I got it on there. What I want to do is, first of all, talk about the story of the day, which is COVID-19. And then I want to try to transition into how does that relate to the underlying issues that we all have been dealing with in rural America for quite some time. And then finish it off with actually a path forward if we can even dare to think of a path forward at this time. But before I start, I just want to touch on three, I guess, kind of late-breaking news items out there right now of importance before I get into my presentation. And number one on that is I want to make sure that I do a shout out, if you will. I think that's how the kids call it these days, to Starr County, Texas. You probably weren't expecting me to comment about Starr County, Texas to you to start my presentation. But unfortunately, it makes the list. It makes the top 10 list today. Every morning I receive an update from the CDC Administrator's Office on COVID-19 and its spread into rural America. It helps from our end to help coordinate resources and attention to those areas that are seeing a surge of COVID-19 patients. And within the last 24 hours, Starr County has seen a 30% increase in COVID-19 patients, positives in that county. Which makes it rank among the top 10 increases of all rural counties in the United States. Probably not a surprise to you. Obviously, Texas is all over the national news right now because of the challenges that you all are facing down there. I want to use that as a point to share with you a terminology that's developed just over the last week, and that is the concept of rural roller coaster communities. How about that? You heard it here first. So that's your benefit from being on the line today. And I want to say that because at this point, we can recognize that there are characteristics of rural counties that actually see a surge of patients and positive cases as well too. And fortunately, I think now we can say there are rural counties that are not going to see surges of rural patients or surges of positive cases of COVID because they are sparse. For a lot of our nation's farmers and ranchers, they really pioneered the concept of social distancing. You know, we've got that down. We had that down before the pandemic. However, if you are in a rural town right now, and this is important, if you are in a rural town that has large populations of people coming into your community, and then you also have large populations of people going out of your community, but while they're in your community, they are in the process of, oops, I stopped my screen is shared there. Okay, resume, there we go. What happens is if you've got people coming into your community and then together in some sort of enclosed building, you are going to see a surge of these patients. And so at the beginning of this pandemic, we saw this happen in resort communities, whether that be in Idaho or Colorado or upper state New York. Then we started seeing surges in rural adjacent to urban. Rural communities outside of Louisiana, for example. Then we started seeing surges in rural towns that were along interstate highways that had large truck plazas, where we had people coming into the community again and infecting people within that rural community. Now, of course, you've heard the national news about processing plants and the impact of that. But let me share with you right now what we're seeing, or at least the CDC is seeing. And I think this is really important, certainly for Texas, is what we're seeing is a lot of urban individuals are thinking, I want to escape the city and let's go out to this resort location out in rural and remote area to the cabin and let's go to the lake. And all across the US, we are seeing these pop-ups of these flares where people are going to these cabins and resort hotels on lakes and other outdoor areas and bringing it in and just infecting the community. So to summarize that, you have these spikes and then they go down, but these same communities are having spikes again, and this is repeating itself. So you have to ask, what's the response to that? What's the policy response to that? And I don't have an answer to that right now, because this is being talked about right now this week at the federal level, is how do we help these communities that have had these surges and then have had them again, are going to continue to have them throughout the remainder of this year. I have to be honest with you, I'm beyond frustrated with the national news at this point saying, what if there's a fall surge? There are surges happening right now across rural America. I mean, I can't even imagine how people in Starr County right now feel about it when they hear people say, well, what if we have a fall surge? Again, they are having it right now. So I want to drop that off for right now for a discussion, and I want to do a hard shift onto research that just came out yesterday, which I think is going to be of relevance to a lot of people on here, not COVID related directly. And that is new data from the Rural Policy Research Institute that shows that over the last decade, 10% of the nation's nursing homes, rural nursing homes, have closed. 10% of the nation's rural nursing homes over the last 10 years have closed. Now, Jay, how are we going to communicate that? I'll be honest, to us, our messaging is going to be, this further shows the closures of rural hospitals, the closures of rural pharmacies, and now the closures of rural nursing homes. You get this decreased access to care, and it results in lower health standards among our rural populations. Okay, but focus in on this, because this is the policy component of this. What is driving this? I don't know, and the research doesn't know right now, and I'll tell you why on this. You're going to see later on as I go through a series of charts and slides. All my charts and slides, no matter what the topic, they all look the same, and that is in the rural South, from Texas clear on over to Florida. You see higher levels of chronic disease. You see rural hospital closures. You see decrease in rural pharmacies. You see workforce shortages. But the rural nursing home closures do not follow that pattern. Instead, we're seeing the majority of rural nursing homes close in upper Midwest, West, and Northeast. So I'm telling you, whatever it is that's driving, and we know what's driving, it's the economics of it, it's a lot of the population's social determinants of health as well in these rural southern counties and towns and states. That's not coming to bear when it comes to nursing homes. So for those of you that actually are actively engaged in rural health policy, stay tuned for this, because I think it's going to lead to a lot of really interesting research, particularly on rural health and how that impacts our communities going ahead. Okay, now let's get into this presentation. Great opening by our speaker talking about the rural hospital closure crisis. Right on the mark with that. Let me just add a little to that. In February of this year, February 1, nationwide, 47% of our nation's rural hospitals were operating at a loss. For all of our nation's rural hospitals, that's 2,000 rural hospitals, 1,300 critical access hospitals, all of them, on average, had 30 days cash on hand. And that's when we plowed into this global pandemic. And as you heard earlier, that's when the rural hospitals stopped elective procedures, generally speaking, stopped outpatient services. which in a rural context represents up to 80% of their total revenue. So in April, we had a dire situation nationwide of just making payroll for these rural hospitals. Fortunately, very fortunately, of course, our membership stepped forward with advocacy efforts, and we were actually able to secure funding for our rural hospitals at that time. I need to make this point perfectly clear. This was a tremendous success for rural advocates. And I say that because when Congress passed this legislation, they had $100 billion for provider relief. Not a word, not a single bit of it was carved out or targeted or directed towards rural. So in theory, when Congress passed this and the president signed it, $100 billion could have all just been directed only exclusively to New York City hospitals. There was no guarantee that any of rural America would have seen a dime from this. However, the administration did step in, worked with NRHA and our members to try to determine how best to make sure that rural facilities and rural communities saw some of this funding, so that way we didn't have a complete deluge of rural hospital closures. And I'm not going to go into the details of this because, quite honestly, you could spend about 6 hours going through each one of these provisions that were included within the CARES Act when it comes to distribution of funds for rural. I'm going to instead offer that you all consider as follow-up, either looking on my slides afterwards or just Googling rural health. Our website should pull up, and we have detailed guides on our website about where this relief is and what you can look for your community and for your hospital in particular. I will say this. It is a tremendous amount of funds that has been distributed to rural hospitals. We have since met directly with Seema Verma, the administrator of CMS, to share with her two key issues. Number one, reporting requirements of all this funds that has been distributed. We want to make sure that rural providers are not penalized for this as we move forward. And also, it's just not a unreasonable reporting requirement as we get out of this, number one. And number two, and this is immensely important, that we retain these telehealth exemptions and regulatory relief that they have implemented through this pandemic. I am not going to extrapolate on that. Everyone on this call that's engaged in rural health knows how insanely valuable these rural telehealth provisions have been. And I'm not talking just for rural hospitals. I'm talking for rural health clinics out there, and the ability to at least keep these doors open on a lot of these rural health clinics and rural community health centers. I will say this, Administrator Verma has been right on board with this, and she has actually communicated directly to Congress as well the need to maintain these telehealth provisions as we move out of this pandemic. So when you've got the CMS administrator telling Capitol Hill telehealth is working, these regulatory changes need to continue, we are aligned exactly as we should be as we move forward in this process. So that is fantastic. But here's the problem, and I got to tell you, this is really difficult to communicate. Some of you may have seen me occasionally on the news. My primary function as we entered this crisis has been really to be on camera about 24/7 on Fox News, CNN, ABC, NBC News. And the message that I've been conveying is the CARES Act stabilized the health center and health system in rural hospitals and rural health clinics today. However, we have a real concern that we've saved rural health today only to kill it this fall. Not stress that enough. These rural hospitals, rural health clinics, rural community health centers have the funding they need right now, but there is no guarantee, there's no plan, there's no movement forward of ensuring that they have the funding they need when we hit August, September, October, November. None, zero. The only hope in a best case scenario, now listen to this, our hope, if this works out perfect, is that right now, all of these rural hospitals, rural health clinics, and rural community health centers can restart business as usual to build back in the normal flow of patients. So that way, as the CARES Act funding goes down, normal business practices can get back up to where they were. And remember, back up to where they were, that means 30 days cash on hand and nearly 400 rural hospitals at risk for closure. So we need a whole nother long-term path going ahead, but that is the plan right now. And I can tell you, in rural counties and rural towns across the US that are seeing surges now, they are not getting back to business as usual. They have to maintain that surge capacity. A lot of rural towns that have not seen a surge of rural COVID patients, yes, they are able to restart their outpatient and elective procedures. But there is a real risk that a lot of these rural communities are not going to survive through the end of this year. So I'll need to make sure that we're well attuned to this issue as we move forward. All right. What we're doing right now is so valuable, and that is sharing what we're hearing, what I know, what I'm seeing, and then hopefully all of you as well in the chat function will be able to share concerns and issues as well too. That's how we normally do this, correct? But in this pandemic, there's been a need to have real-time information shared. And I just want to point out from our organization, NRHA, we have a member-only communication tool, NRHA Connect. And so from a member standpoint, it's been great because when they have questions about funding or processes, they can post it online, they hear back. From an advocacy standpoint, it's been immeasurable. I just can't share with you how valuable that's been, because we hear from our members in a private setting, and then we are able to convey that directly to the White House and to Capitol Hill and to the media as well too, about what we're seeing and what we're hearing, and there are still the challenges from a rural context on that. I'm really hopeful that we all get back to the normal very soon, just recognizing that I don't know when that's going to happen, right? Does anyone know when that's going to happen? We just last week concluded our first online conference, and as you know, we're participating in one right now as well too. As of right now, at this very second, we are planning to be face-to-face for our fall Critical Access Hospital Rural Health Clinic Conference in Kansas City. But I got to tell you, on Monday of next week, Kansas City is going to decide of how they're going to proceed this fall. And chances are very likely, looking at the surge of cases in the Kansas City metro area, in Kansas and in Missouri, that we will not be meeting face-to-face, and that for the foreseeable future, this is how we're all going to connect. So I think it's a good opportunity for us all to learn how to use this technology. All right, I'm going to shift into fundamentally what makes rural unique. And to do that, I'm sharing this slide right now. And that is to highlight the point that as you're hearing on the national news that we're on the downswing from COVID-19 cases, in a rural context, this whole story shifts to rural America right now. It does. New York City's decreasing, rural America is increasing across the board. And this is not something that comes as a surprise to anyone. It's not a surprise to the CDC. It's not a surprise to the White House. It's not a surprise to Capitol Hill. So I want to assure you of that everyone that needs to know that this is now a rural story knows it. So that's the good news. And FEMA is directly aware of this. And so that's the good news. So let's unfortunately talk about why this is a rural story right now that we're facing. It's who we are. That is us. I mean, rural America is older, sicker, higher degree of chronic health issues. And in many rural communities, these rural communities are multiracial populations. So, and that's in these rural towns all across the U.S. And so if you were to design a system that would be bad for a global pandemic, it would be rural America. And I want to stress this. You see constantly on the news that the elderly is more at risk for COVID-19. Those with hypertension are more at risk for COVID-19. Those with COPD are more at risk. Let's be honest, in a lot, if not most of our rural towns, we've got a significant population that checks at least 6 to 10 boxes of at risk for COVID-19, clustered together, going to Walmart together, going to the grocery store, and going to church all together. And so what we're seeing is when urban individuals come into these communities and they're like lighting a match for these populations that are clustered close together. And this is not going to get better. This slide right now that I'm sharing with you takes a whole new context to when I pulled it up to present to you earlier this year. Looking at the U.S. Census over the last 5 years, don't listen to the national media. What's happened over the last 5 years is urban areas have decreased in population. Rural counties have actually increased in population. Yes, rural America is on the upswing nationally. That was before we discovered that rural America is actually urban America's pandemic escape plan. The first thing people want to do when there is a pandemic is get out of the cities, whether it's Dallas, Houston, New York City, and get to rural America. And now that everyone realizes that for many of these upper income urban people, they can work from the dark side of the moon, now they recognize that, hey, I can live in this great small town, do my work, and get quality of life. That is going to transform how all of us approach rural health, is it not? It is one thing entirely when your community expects there to be primary care and general surgery. But now when you've got a movie star moving into your small town that wants to have 15 different specialists and behavioral health professionals for their family, it just enters into a whole new slew of issues, concerns, and policy issues as we go forward on this. Now, I guess the good news is that hopefully we'll balance out our rural populations a little bit better. Now, we talked earlier, and you heard from the speaker about the issue of Medicaid, and I know that Texas is still struggling with this issue. Medicaid, to me, when we talk about rural America, is a case of it is what it is. And that's when you talk about policy, it is what it is policy. And unfortunately, no matter your public background on this, the fact of the matter is rural America has a disproportionate share of low-income individuals that are seeking care at healthcare facilities, and they're clustered together. If from an economic stratification level, everyone was evenly dispersed among the United States, we wouldn't have rural hospital closures. Rural hospitals fundamentally, every rural hospital that closes has a different reason why they close, but fundamentally, it's simply because they are treating too high of a percentage of patients without health insurance. It is a financing issue on that. And literally, until we deal with that component, we have to recognize that these populations simply are clustered too close and together in these small towns, and it creates an issue. It creates an issue not only because there's a huge percentage of low-income individuals in rural towns, but among that population, just huge health disparities across the board. Again, and I want to emphasize this, these are challenges that we all have faced for the last 30 years, but now a global pandemic just highlights, emphasizes, and ratchets these concerns up to a whole new level that we have not dealt with before. To map, and look at these maps and tell me if you're seeing what I'm seeing. First, these, like I said, are Medicare patients with multiple chronic conditions. This is a current map of our membership and where we're located at. I'm going to switch back here. Multiple chronic issues, NRHA membership. Now visualize where you're seeing the uptick in surges in COVID-19 positive patients. Yeah, these three maps are directly overlaid right now. You could use NRHA membership map if you want to know the states that are surging and increasing in patients right now. I mean, literally Florida, Texas, Arizona, California, Missouri. Have I missed some? These heavily rural communities are now dictating the current process of COVID-19. Okay, a little bit of a shift here. Not even a shift. During this pandemic that we're facing right now, behavioral health issues nationwide have just been exacerbated, well documented that they're on the increase. And a lot of these then have that component of substance abuse issues as well too. Good news, bad news here. This has been a long-standing problem for rural Americans. Everyone on the call knows this. The pandemic has made these issues and concerns even worse. So that's bad, that's worse. But the good news is, and if any of you disagree with this, please share this in the chat room. I'll be happy to follow up with this later on. But because of the significant relaxation in behavioral health telehealth applications, at least finally we have telehealth as a viable treatment protocol and option when it comes to rural communities. Data has shown that rural Americans, we are not inclined to go see a behavioral health specialist. Let's be honest. But there's something about talking in a video. People are more comfortable talking in a video setting, and certainly for behavioral health, that the data shows that. So I'm hopeful that that is a silver lining to what we're dealing with right now. Okay, the last speaker we had that really covered the rural hospital closures, and he did mention about this dip and the wave that we're seeing right now. It's interesting. I will highlight this, that what did we see this year? From January until April 15th, we saw 12 rural hospitals close, 4 closed in April alone. 12 already closed in April, by April, 4 in April alone. I cannot believe I'm saying this, and I don't want to say it because I'm afraid I'm going to jinx myself, but in the month of May, we had 0 rural hospitals closed. 0 rural hospitals closed, and we have not seen one in June yet as well either. The CARES Act funding temporarily put a halt on this closure crisis. Again, we are absolutely not out of the woods, and that's because what drives this, multiple different issues, health disparities, healthcare policies, we covered those. I want to point this because it's kind of, it expands on what you heard from our opening speaker on this. Rural hospital closures, 130 that have closed in the last 10 years, Texas leading the pack. If you look at this, and this is supposed to be a map of the US, if you can make that out, you're seeing that this happened primarily Southeast United States. And with the exception of Texas, although it impacts Texas as well, most of these rural communities that closed with rural communities with high African American populations. So that's what has happened. And to the point, Medicaid expansion actually did help stop some of those closures. Here's what is happening, and as I mentioned, half right now are operating in a negative margin. But you've seen that this closure crisis is no longer just the Southeast. It's moved to upper Midwest. That's where we're at now. And here is a look ahead. This is, again, pre-pandemic data. So we certainly don't know the impact of the pandemic is going to have on this. But what you're seeing, it's no longer a Southeast issue. It's now an upper Midwest, Northeast, West Coast. It is spread throughout. It is now impacting rural hospitals that have high levels of bad debt. And I hear again and again when I'm talking with rural hospitals in Indiana, Nebraska, Washington State in particular, what they're seeing is patients have health insurance, but they haven't met their deductible. They show up at the critical access hospital, rural PPS. They can't meet their deductible. They can't pay the hospital. They're transferred on to the urban facility. Now they met their deductible, and the urban facility receives 100% insurance reimbursement, and these rural hospitals are left holding the bag. So I literally, it's impossible at this point, with so much of the revenue decreasing, the CARES Act funding coming in, and the unsure nature of whether rural hospitals will be able to transform back to normal, to have any idea of what we're going to see for the next 5 years when it comes to rural hospital closures. It's just unknown. What we do know, though, is rural hospital closures results in mortality. I cannot say this enough. This is not an issue that we're worried about, a 1940s built building, bricks and mortar. Rural hospital closures result in increased mortality. The data shows it. So this is an issue about patients and patients' lives going ahead in our rural communities. It's not just a hospital structure issue. One thing that's been a little bit challenging for us over the last 4 months is lack of data. We've been blessed over the last 10 years of having really good, solid data from research, rural relevant research, looking at what's happening and what are the drivers behind rural health and rural health policy. And we use this data and we use this research, a lot of it that's published within the Journal of Rural Health, to make our case for sound, prudent policy. We're in a time right now where we just don't have really solid data. And I open with that, talking about not entirely sure knowing why rural nursing homes are closing, not entirely sure knowing what are the policy levers to pull to stop these rural roller coaster communities who see high levels of patients and then don't, and then high levels of patients. So our main strategy at this point, as a result of not having a lot of, honestly, is just going to the media and making sure we're talking with the media about at least what we're seeing here as we go ahead. I'm going to wrap up to try to keep you all on schedule for your program. This is a listing of all the rural relevant legislation that's currently being considered in Congress. You will have a copy of this slide. But in my mind, at least, when we talk about the future, this pandemic really highlights that we need to make the transition, instead of treating sick care, both in rural health clinics, rural community health centers, and rural hospitals, to keeping our communities healthy. And there needs to be a stable payment mechanism for this. Right now, the only model being tested that might meet these needs is the global health payment model currently being tested in rural towns in Pennsylvania. There's close to 20 rural hospitals that are currently involved in this global payment model going ahead. But I roll this back, and why this is so important to wrap my presentation up on this is we just saw a situation where rural hospitals had to stop all the revenue coming in to prepare for this pandemic. The government had to throw $100 billion at this, and now these hospitals are trying to ramp back up their volumes. Meanwhile, 20 rural hospitals in Pennsylvania didn't have to worry about this at all. They were guaranteed a level payment as they worked to make sure they addressed the pandemic and COVID-19 patients in their community. They are where we should be. And if we were in this model, this payment model for rural communities going into this, well, we'd have a much different conversation right now, right? All right, I have wrapped up and I have kept you almost on time. Let me close with this, and this is so important, and certainly from a Texas context. Let's keep rural health nonpartisan, please. We are simply just not going to be able to keep access to healthcare in rural America there, present, and available if we aren't able to keep this nonpartisan. And I think a lot of what we're talking about and what we've communicated here are all issues that can be addressed in a nonpartisan manner. So I'm going to stop right there, and I'm going to ask if there are any questions, to make sure that you type them in the chat room. I'm going to stay online and answer them as come. But with that, I will turn the program back over to Mike. Mike, I can't thank you enough for the opportunity to speak here. I hope the volume was okay. And I want to conclude and leave you all with this. My poor wife has lost her office. This is her office. I'm stuck in it right now. I need Mike Easley's office with his gun safe in the back. I don't know who decorated my wife's office, but I'm talking to her right after this presentation. Mike, it's right back to you.